Good morning, everyone. Welcome, and thank you for joining us for another HRG Outbreak Outreach webinar. As we continue to navigate through this unprecedented time, HRG is continually committed to sharing the industry information and best practices that you're accustomed to getting from industry events like HFMA and AHIMA meetings that happen throughout the nation. Before we get started, I just wanted to give you guys a couple housekeeping rules. Feel free to ask questions as they come up in the questions box in your control panel. To make sure that we honor the time that we have allotted for this, I know it's just a quick 30 minutes. We want to make sure that we get your questions answered. We will send out those answers in an email after the webinar. Also in that email, we'll have a survey where you can request a certificate of attendance for joining us this morning. If that is something that you guys are looking for, feel free to just request that in that survey. With that, we're going to go ahead and get started. This morning, we have HRG's Executive Director of CBO Services, Cassie Wise, joining us to talk to you guys and let you know everything that you need to know on managing denials. With that, Cassie, go ahead and take it away.
All right, perfect. I hope everyone can hear me. I just wanted to start out with a little bit of a disclaimer. Since we're all working from home due to COVID, I've got one-year-old twins here that you may hear in the background. My husband's trying to keep them corralled in the living room, but they've got pipes. So if you hear kids screaming, I promise it's just one-year-olds having a party. All right, so let's go ahead and get started. So I just wanted to get on and give everyone a presentation on conquering denials and what we've done at HRG and what we've seen be successful. So we just want to give a little bit of insight on that. I'm going to run through this fairly quickly because it was about a 1-hour presentation, and so we want to keep to that 30-minute timeline. So I'm going to go through things a little bit quickly. So if you have questions, feel free to, like Taylor said, put them in the questions box and we'll get back to you on them. So let's get started. All right. So what we're going to go over today is why. Why do we have denials? Talk about what we're up against, what we're seeing nationwide out there, how to gather the data needed in order to track denials, gathering the troops, who all needs to be involved in denial prevention, how to take action, and then how to monitor your results after you've taken that action. All right, so the easy answer to why we have denials is claims recovery is complex. But we all know that. The real answer is that we've got government regulations that are changing basically on the daily that we have to keep up with, which in turn can end in denials. We have insurers that are tightening their belts, so they want to. They've got a bottom line that they're trying to keep, and so they've got to make sure that every penny that they're giving out to facilities is just dollars. And then really one of the larger things that we see a lot is just lack of communication between patient financial services and other departments in the facility. So before a claim reaches the billing team, it may have been touched by upward of 25 different people or more. There's a lot of things that affect claims before they drop. And if you think about it this way, from the time, even sometimes before the patient walks in the door, if they've got some pre-op stuff happening, but even before the patient comes in the door, some of those puzzle pieces that need to be in place for a clean claim to go out the door have already started to come together. So every step along the way that patient is being seen through the coding and billing process, it's picking up little pieces of the puzzle that create that clean claim. So if there's any issues with any of those pieces of puzzles along the way, it will result in denial. So it's really important to understand that all of these different things listed on your screen right now can affect a clean claim. So when you have so many different departments and systems and processes in place, it's really easy, and I'm sure you've all seen it. Finger pointing occurs. We have PFS saying that it's HIM's fault. We have HIM saying that it's radiology. Radiology saying it's lab. So we've got some suggestions further along in the presentation that we can go over that I've found have helped in the finger pointing aspect, that it's just inherent with the process. Nobody wants it to be their fault if money's not coming in the door. So what are we up against? So nationwide, on average, about 10% or $262 billion of claims nationwide are denied upon first submission. Of that 262 billion, about 90% of those were preventable. So what we know is that denials are never going to 100% go away, but about 90% of the time, based on the denials that have been received, 90% of those could have been prevented by one way or another, whether that means checking for medical necessity up front, not providing services potentially if they're not something that are reimbursable. But then there's always going to be those ones that are out there, things like coordination of benefit or accident questionnaires that are going to end in denials, but you don't know that when you send the claim out the door. So it's important to know that there still is going to be denials, even if you get your denial program as clean as possible. So we wanted to take a look at, and this is just another slide that depicts the 262 billion that were denied. Of that, 165 billion or 90% were recoverable. The really important thing, and I think the one takeaway here, is that $107 billion of that 165, so about 63% of it, wasn't recovered. So that just 100% equals money left on the table. So what are we up against? Always remember that the receipt of a denial, and I've kind of said this already, does not necessarily mean loss reimbursement, but it does always mean additional labor. You're always going to have somebody working those denials, and so it is going to come to a cost for you in additional labor. Denials will never be completely eliminated. I don't want to stress that enough. But what we'd like to see, or what the best practice target nationwide is about 5%. But we've seen nationwide that it sits at about 10% currently. So HRMA has actually updated the way that they formulate denials. It used to be on dollars denied versus dollars remitted, and now they've changed it to the number of claims denied versus the number of claims remitted. I think either way is a good way to measure it. The most important thing for everyone to know is that as long as you understand what's behind your denials, and you understand what's being recorded, you're going to be able to make an impact on it. How you measure it, whether you do it by count or by dollar, is really what fits your facility best. If you're a clinic and all of your claims are typically around the same dollar amount, it may make more sense to go by count. But if you have a facility that has all different service types, and you find that the dollars that are being denied on high dollar claims is a better focus for you, then you may want to look at it by dollars rather than count. One thing I did want to point out also is that if claims remitted data is not available for you, so the actual remittance advice is coming back that have the allowable or the charge amount on there is not available to you, then claim submission data can be used in its place. You can get into your claims scrubber and just take a look at the data that was going out versus the denials that were coming back. So that's an alternative if you're not able to get claims remitted. So gather the data. There are some systems out there. Quadex, for one, does it, and I know that there's some just regular denial software that's out there as well, that do have denial management software and will give you this data back right out of their reporting system. If not, there is software also out there that will do HIPAA Suite is what it's called, which I've seen people utilize before, where it will kind of descramble that remit for you and bring it back with just the fields that are contained in that 835, so that you're able to gather some of the denial data from there. If you don't have any of that software, a regular old Excel spreadsheet will work as well if you have your staff just fill in the denials as they've received them. And just make sure that they're tracking things like the date denied, payer that denied, the amount, the reason, and the most important thing, and I want to kind of hit this one home, is the action taken to resolve that denial. I've been a part of board meetings before where some of the board members didn't understand when a claim was denied that it actually was not lost cash necessarily. Like we saw, 90% of the time they're recoverable when you do get a denial, but sometimes people just look at that number and see, oh my gosh, I had $700,000 in denials, I'm never getting that money, when in reality you are getting 90% of that back through the rebilling process. And so I always like to look at action taken to resolve the denial as well, because for another reason, if the action that was taken on those denials were things like transferred to self-pay or they were written off, then we may have a problem with registration and then also vetting the charges that we have coming through the door. Because if we're writing them off, then maybe they weren't reimbursable to begin with, and we need to look at the process up front to eliminate that from happening. Gather the data more. So you want to condition your denial data into root cause areas. So for example, these are the examples of the root causes that I typically see used. A lot of them, so for example, billing denial might be a wrong type of bill, or a coding denial might be something that was denied for medical necessity. I always like to talk about coding because I think it's kind of a hot button subject. A lot of times the coders haven't necessarily done something wrong when we get a coding related denial. Basically what those coding denials mean is that there was something that had to do with the diagnosis versus the charge. So sometimes there is no diagnosis that they can find that is going to cover that charge. So it doesn't necessarily mean they did something wrong. I think if you could take one thing out of this presentation today is denial management is something that is a full facility engagement. And so you have to have players from all different departments involved. And it shouldn't be looked at as, it should be looked at more as an object and not trying to pinpoint it on somebody. We're not trying to attach the denials to a certain department. We're not trying to attach the denials to a certain person. We're just looking at the facts and coming together to put a plan in place so that we can reduce those denials. Because I work at HRG, I have access to a lot of data, which is really nice. So I was able to pull about $343 million worth of denials from a remit that we have either worked with clients on or just received through CBO services. So I was able to come up with a cumulative list from 100 plus facilities. And you might be surprised that this is the percentages that we came up with when we categorized those high level denials. And the reason I say you might be surprised is because a lot of you that are in the PFS arena, the denials that you see coming through, I think you may have thought that coding was higher than this. And the reason that I think that anybody who works in PFS thinks that the coding denials are much more abundant than 9% of them that are coming through the door is because those are the ones that frustrate them. Those are the ones that they can't resolve themselves. They have to send out for someone else to do for them. And so it just sticks in their mind much differently than if they were updating a registration or authorization, or they were just fixing a type of bill or updating a place of service. Those are all things that they can do and get out the door again. But those coding ones have to be sent next door to be looked at. And so I think those ones resonate with them a little bit more. So just to put this into perspective, this was about $343 million in denials. So when you look at the overall denials nationwide, that 262 billion, or maybe a little bit more than that, about 0.1% is what we're looking at right now. So I had access to 0.1% of the denials received nationwide. And so your mix may look a little bit different from this, but it's just a good practice to look at and good information so that you can compare yourselves to what we're seeing. We have hospitals all across the U.S., and so anywhere, Alaska, Hawaii, and then the lower 48 as well. So we're kind of, we've got a mixed bag here from all over the country. So I'm going to run through these really quickly. These are just the top 3 reasons for each of those root cause areas. So in billing, duplicate claims, untimely filing, and EOBs from primary required were the top 3 reasons that we saw those billing denials come back. In coding, it was service included another procedure, denied diagnosis, CPT code related denial, and invalid value or occurrence code or modifier. For registration and authorizations, it was authorization missing or invalid, coordination of benefits, and patient not eligible on data service. I want to point out coordination of benefits on this one because it is a top 3 denial, and this is one that I was able to put an example together for and show you what we have worked with facilities to create so that they can reduce their coordination of benefits denials. So they, when we realized that coordination of benefits was a large issue in a couple of clients that we work with, we've created this kind of job aid or cheat sheet for the registration staff so that they are able to just refer to it if they have any of those kind of tricky coordination of benefits patients that come through the door. We have them in nice cardstock, 3rd sheet postcard like setup. So if any of you are interested, they're going to put it in the survey. Just go ahead and put your information in, and we'll send you a 5-pack of them so that you have them and can hand them out to your registration staff if you're interested. But this is just an example of one of the solutions that we came up with so that we could reduce those coordination of benefits denials that we saw coming through the door. Additional information requested, it was about 16% of the overall denials, and those were requests for medical records, accidents information, and physician sign-off required. You may be thinking right now, why do you have medical records requested listed as one of the denials, quote unquote? And the reason for that is that we want to track it. Because to us, anything that is causing a claim delay, whether it's a hard denial or not, is something that we want to watch. And I'll get to more about that further on in the presentation, but I'll give you a really good example of why you want to, whether you're including them in your denial percentage number or not, you do want to make sure that you're tracking them. So about 4% of the overall denials were contract and credentialing. And about 7% were utilization review things, so plan limits that were exceeded or medical necessity that wasn't established for inpatients, that sort of thing. Okay, so now on taking action. So the first thing that you want to do, and I've talked about this previously, is create a denial committee. So it needs to include a team member from each root cause area. So sometimes I get a lot of questions about lab and radiology and utilization review being included in these meetings, and my advice is always include them if you're seeing a trend where there are denials that are coming out of potentially the processes that they have in place in their department. They don't have to go to every meeting. Once their issues seem to have resolved, then they can stop coming, but always invite people because you want to make sure that they feel like they have skin in the game and that they care about that number and those particular denials that they're working on. You want them to want to come to the next denial meeting so that they're able to see if the processes that they put in place have yielded results. You want to schedule them a monthly meeting with that team once you decide who those team members are. And then each month you want to review the denial data as a team. So together, look at the data. Typically what we do is pull out the top 5 or 10 denials based on either count or dollar, whatever works best for your facility. And we assign owners to those. So for example, we'll just go back to coordination benefits and pick on that one. So if we have a lot of coordination of benefits issues or a lot of denials with coordination benefits, then we would have the admitting supervisor take that one on as an owner. So they would talk about what their process is that they're going to do, any changes that they're making, and when they plan to put it in place. It's really important to remember that when you put a process in place, that has to go through the whole billing process before you're going to start seeing results. So it's typically about a 2-month lag anytime that you try to incorporate any fixes to denials. Because you have the claim processing time included in that. So just keep that in mind, because sometimes if you have people like lab or radiology that are, they're gung-ho, ready to go, and they make changes and they come to the following meeting and they're just defeated. Like, I made all these changes and I'm not seeing the results. And so it's good to remind the people who aren't in the day-to-day billing office that it takes about 2 months in order for you to start seeing the fruits of your labor. All right. So let's talk about measuring results. So you want to distribute the denials details each month prior to the committee meeting. Each department should address their progress, and it's really important to celebrate positive movement because if there's in denials, there's not a lot of fun. And so when you start seeing that the stats start to decrease, make sure that you're celebrating it because it's not easy. It's not an easy feat. These are a couple examples of reports that we've utilized with clients. It's a few different looks at how a denial report can be put together. This one has the denials by payer, and then it also has the root cause origin as front end, mid-cycle, and back end. The reason that the front end, mid-cycle, and back end was utilized in this one is this particular facility had a problem with pointing fingers at people because of the root cause areas being registration or coding. So this was a way that they combated that and detached those denials from the individuals that people felt like were at fault. And so once they did that, they were able to start working more as a cohesive team because they no longer had those denials attached to humans anymore, and they were working together much better. You'll always see in any of the reporting that I'm involved in anyways, I like to look at both count and amount. It gives you a view both ways so that it helps you make a more educated decision on where you want to focus your efforts. This is just another look. This one does have the denial origins as the billing coding facility. So these ones are a little more specific than that front end, mid-cycle, and back end. Again, by count and amount. This page I really like because it gives you an idea of there's always the struggle. High clean claims rate and low denials is what we want in the end. And sometimes when you're working on increasing your clean claims rate, you may see that your denials increase as well. I always say it's more important to me to have maybe a little bit dirtier clean claims rate if it means my denial rate is a little better. And the reason for that is high clean claims rate does not get your cash in quicker if there are claims edits that are missing. So you always want to make sure that you're balancing your clean claims rate and your denial rate and that one is not negatively affecting the other. And then again on this page, the actions taken on denials, I'll say over and over and over again, is the most important thing. That is what's going to, when you put your head on your pillow at night, help you sleep. If you have a good understanding of what happened with your denials, then it's going to make you feel a lot better. So for example, on this chart, of the 525,000 that were denied in January of 18 on this report, 334,000 of those were rebuilt. So we know we sent those ones back out the door. This also, like I was saying earlier, is going to give you an idea of if you have a problem somewhere. So for example, if you have a lot of adjustments, things that are being written off, it's going to take your eye to it and help you hone in on what those things might be and how we can fix those up front so that we're not ultimately writing them off at the end. And then once you have your denials all under wraps, I always like to talk about creating a payer scorecard. And this is where when we were talking about the medical records, counting them as a denial or not, and you just saying we really just need to track them. And I've got an example for you. I have a client that they have high swing bed utilization, and they had a United Healthcare HMO, and when they were sending their swing beds out, United Healthcare was requiring medical records. United Healthcare would not let them send medical records with the claim initially when it went out the door. They had to send the claim, get the medical records request back, and then send records. At that point is when United Healthcare would start their claim processing clock. So at that time, we've already lost 3 or 4 weeks. So the time it was taking to pay those claims was anywhere from 6 to 12 weeks to get those claims back in and paid. And so it's really important when you're tracking your denials to think about those things, because you can then create a payer scorecard and that will assist in resolving some of those payer-related issues. And that's why I say whether you're counting as a denial or not, always track those things that are causing claim delays. So some of the things you might want to put on a payer scorecard are things like average time to pay, what the denial rate is, what the AR days are for that payer, and what the payment accuracy is. For that client that I mentioned earlier, they were actually able to talk to the insurance and tell them, hey, you requested medical records from me every single time. You want to allow me to send them initially? And in our contract, it says that you're supposed to make payment on the claims within 30 days. That's not happening right now, and it's by something that you've caused. They were also able to go back and look at every time they requested medical records and how many times that claim was ultimately denied with medical records not being appropriate. And because that happened 0 times, they were able to tell United Healthcare, I've done nothing wrong. I've had a 100% accuracy rate, and you're causing my claims to delay longer. So it gives you a lot of ammunition to go back and talk to your payers and really meet in the middle on what's necessary for them to have and still get your claims paid in a timely manner. So takeaways today are gather the data, gather the troops, take action, and then monitor your results, and you will conquer your denial. Every good presentation ends with a good quote. So denial management is not easy, but just always remember, over every mountain there's a path, although it may not be seen from the valley.
Awesome. Great job, Cassie. Thanks for sharing that information with us. So you guys, I just wanted to let you know, as I had mentioned earlier, we will be sending out an email this afternoon. That email will include the slide deck, the recording of today's webinar that you can share with your team. If there are any questions that were asked throughout the webinar, we'll also answer those questions there. And then most importantly to us right now is that you guys just let us know how we're doing. So we will have a survey in that email as well. Please let us know what you think of these. If you have ideas on topics that you'd like to hear from us on, of course, let us know as well. We do have a full lineup of webinars going out through the middle of May. Next week, we will have our executive vice president of our Out Partnering Center presenting on self-pay in regard to the COVID-19 crisis, making sure that we can help you guys keep self-pay alive and just keep being productive throughout this process. So keep an eye out in your email for that. I do also want to reiterate, in the survey, you have the opportunity to request the hard copy of the rules that Cassie had shown you that she had mentioned you can request, as well as a certificate of attendance. So feel free to do that. With that, we're going to let you guys go. You have a great rest of your day, and we will see you next week.